And as Paul Batalden is so eloquently stated, every system is perfectly designed to achieve the results it generates. Now, why is this important? What it tells us is that these clinical microsystems, these 52 clinical microsystems, which were all outpatient clinics, are providing a level of care that's going to make it very difficult for those residents to learn effectively how to deliver high quality care to older patients once they leave the program. It's not like an on-off switch. You simply can't talk about providing good care. You actually have to experience doing good care. And what this study shows us is that right now, among the older patients seen in our training clinics, in this case internal medicine, family medicine training clinics, the level of care that they're delivering is suboptimal, and also makes it difficult for the trainees to acquire these skills that they need to effectively care for older patients in their own clinic once they graduate from the program. We also know that this is a national need. In fact, as the IOM has recently noted, with our aging population, there's going to be a critical need to be able to deliver this kind of high-quality geriatric care to keep patients out of the hospital and to maximize their function toward the later years of their life. And we need to make sure that our systems are designed to deliver good care so that they can actually acquire those skills needed for the care of the elderly. So this is a nice example of where dysfunctional systems, unable to provide the kind of quality of care needed for this population, is affecting the training of these trainees as well. So with that kind of example, with that data, I'd like you to reflect on your own program. Again, through a thought exercise. What potential quality and systems problems are residency clinics experiencing with the care of older adults? Okay? What are your system problems? And if you think back to those success characteristics of microsystems, which of those might be contributing to making it challenging to you to deliver high quality care to your older patients in the training setting? And also think about what practice-based learning and improvement and systems-based practice skills and roles may be required on the part of the resident to address this current state of affairs, specifically for the care of older patients, identified as a national priority and something all training programs, not just internal medicine or family medicine, need to take on, but everybody needs to take on. So I'd like you to think about that a little bit as you reflect on the data that I just showed you and how well you think you might be doing, whether it be in a surgical clinic or an internal medicine clinic with regards to the care of your older adults. So as you're kind of thinking about the systems issue and in particular example of caring for older adults, I'd like to end with looking at another what I call educational systems issue, and this is transitions. You know, as we think about the design of our educational systems, transitions are a major part of those, and they are truly a systems issue. So I'd like to return now to the slide I showed earlier about the architecture of medical education and focus specifically on those transitions. During the educational period for physicians, they undergo a number of transitions. They start in both medical school and then in residency or fellowship training. As we can see, during medical school and residency, we tend to approach our educational design through a series of rotations. And each of those rotations have a set period of time, and they require the trainee, whether it be a student or resident, to make a transition from one rotation to another. What that means, particularly in the clinical years for students, and obviously in residency, is that transition is more than just an educational transition. They're also transitioning between clinical microsystems, as we mentioned earlier. And so what is it like to have to make that transition? Are all microsystems the same, or do they have unique characteristics? And I think we'd all agree that they often have unique characteristics that residents have to adapt to. In addition to these educational transitions between rotations, they certainly have a number of daily transitions that we talked about earlier. And these are also very important, not only from an educational point of view, because this is a major part of care coordination and safety, but obviously they have major implications for the patient. Again, highlighting the tight interplay between clinical care and education once you've entered the clinical training years. So let's just take a look at the kind of bottom part of the diagram with this issue of daily handoffs. We've known for a long time that these are frequent and that the duty hours standards have certainly played a role, but probably not as dramatically as everybody thinks. For example, the first round of duty hour restrictions enacted in 2003 did increase the number of handoffs, but what was interesting, as you can see, for example, in internal medicine, on average, it only led to 1 to 2 more handoffs per week. This is wonderful work done by Leora Horowitz at Yale University and published in the Annals of Internal Medicine in 2006. So the reality is, handoffs have been a major issue for us for quite some time. And what are the issues around handoffs? Well, they tend to be error-prone, variable, and it has been this way for a number of years. And we call these the white space of care because oftentimes in a handoff, there's no clear accountability as to who takes over what and when. So from the person who's doing the handoff to the person on the receiving end, there's that period of time before that actually is complete where there might be actually white space, and that can lead to problems. And what's been interesting, until recently, few trainees have actually received any formal education on how best to do a handoff. Now that's changing, and the good news is that we're beginning to work on that. But I just like this diagram from Reasons talking about the model of error, known as the Swiss cheese model of error, how dependent we often are on our trainees to fill those holes. So in the Reasons model, you have a bunch of what are called kind of latent hazards, and that there's often safety nets that present those latent hazards, shown up on the upper right-hand corner, from actually becoming a true loss or an active hazard or an active loss. But we all know each safety net often has a hole in it. And sometimes all those holes line up, and that latent hazard becomes an actual loss. And we often depend on our students, interns, and residents to be the ones who are the safety nets and to fill the holes. And so that often puts them at quite great risk and stress. And the more that we can improve, for example, handoff processes, the more that we can avoid this kind of lining up, if you will, the holes that lead to an adverse event for patients. There are systematic approaches to handoffs. Again, this is an important systems issue. I'm just going to highlight 2 of them and encourage you that if you're interested, there's lots of literature on both approaches, but it's beyond the scope of my talk today to talk specifically about how best to use these. The first is SBAR, which stands for Situation, Background, Assessment, and Recommendation. And essentially, these are the 4 categories that should be covered when somebody is handing off a patient during a care activity. So when an intern is handing off a patient to go home for the night to the on-call intern, it would be important that the intern describe the patient's situation, important background information about that patient, what current assessments have been done and what assessments need to be done, and finally what recommendations the intern who's on the receiving end should receive for that patient that need to be done, let's say in an overnight call. The other model is called Anticipate. And again, here, the information or the structure of the information that should be provided in handoff are the administrative data, any new information pertinent to that patient, such as a clinical update, task, what needs to be done for that patient after the handoff, illness, is the patient ill, and if so, how ill, so that the person on the receiving end understands how ill the patient is and how much attention the patient should receive during, for example, the overnight call. And then finally, contingency planning or code status. What should the intern on the receiving end do should something potentially go wrong with the patient on an overnight call? So Anticipate and SBAR are 2 systematic approaches to structuring the handoff process that I encourage you to take a look at as an important system issue within your training program.